I am Dr. Ayman Nimr, Professor of Surgical Oncology. This is the third lecture in liver surgery about benign hepatic tumors. The objectives of this lecture is to identify the most important features of common benign liver tumors. Benign hepatic tumors are a heterogeneous group of lesions originating from different cell lines within the liver. I chose the term lesions rather than mass because the lesion is a term that has a wider application including solid and cystic masses. Benign hepatic tumors are frequent lesions which have a dramatic rise in detection. Sometimes they are termed incidentalomas. They mostly affect young patients. And this heterogeneous group of tumors have different biological and clinical features and have different natural histories. Benign hepatic tumors are either solid or cystic in nature. The solid tumors arise from the epithelium or from the mesenchymal tissues. The epithelial tumors including focal nodular hyperplasia, liver cell adenoma, bile duct adenoma, and papillary adenoma. The mesenchymal tumors including hemangiomas, hemangioendothelioma, lipomatous tumor, leiomyomas, and mesenchymal hamartoma. The cystic tumors are simple cyst or polycystic liver disease and biliary cyst adenoma. These tumors may arise from the liver tissue and including hemangioma, focal nodular hyperplasia, hepatic adenoma, lipomatous tumor, infantile hemangioendothelioma, mesenchymal hamartoma, and inflammatory pseudotumors, or may arise from the intrahepatic biliary tree, like biliary cyst adenoma, bile duct adenoma or hamartoma, and papillary adenoma. Hemangioma. Hemangioma is the most common benign neoplasm of the liver, usually affect females at any age. It is an incidental finding, typically asymptomatic and rarely diagnosed until adulthood. Hemangioma may be solitary or multiple. It often occurs in the posterior sector, I mean segment 6 and 7. It is usually more than 5 centimeters in diameter. However, it can be very large. Typically, it remains stable in size but may grow. Pathologically, hemangioma is composed of many endothelium-lined vascular spaces separated by fibrous septae. The blood supply is from the hepatic artery. This is the gross appearance of hemangioma. As we see, it is composed of many vascular spaces which vary in size and containing blood. And this is a cut section. It may show fibrosis in the center, and it is also complicated by areas of hemorrhage. By conventional ultrasonography, hemangioma appear as we see, a well-defined, uniformly hyperechoic lesion with peripheral feeding vessels. Sometimes the hemangioma can exhibit a posterior acoustic shadow. Contrast-enhanced ultrasonography, their typical pattern is globular with peripheral enhancement on arterial face, which with progressive centripetal filling that usually complete during the late phase. In larger hemangioma, unenhanced central area correspond to the intralesional fibrosis or thrombosis. By contrast, enhanced CT spiral CT examination, the characteristic finding is the sequential contrast opacification, which begins at the periphery, and so in the arterial face there is a peripheral budding, as we see here in this diagram. In the portal phase, the filling continue in a centripetal fashion. In the delayed phase, the lesion fills completely with contrast and become isoattenuating in relation to the surrounding liver tissue. The hemangioma may not enhance completely if large. or have a central scar. These films obtained by contrast enhanced spiral CT examination. As you see in the arterial face, there is a peripheral budding of the contrast. In the portal face, there is a progressive enhancement. In the delayed phase, we can see the complete enhancement of the mass, which appear slightly hyper-attenuating due to the delayed washout. Hemangioma appear in T1 weighted image MRI as a hypo-intense and well-defined lesion, and in T2 weighted image, as we see in these two slices, the hemangioma is markedly hyper-intense that increase with no equal time. Angiography is the gold standard diagnostic tool. It can show the normal main artery and feeding vessels. It can also demonstrate the early contrast accumulation within the lesion during the late arterial phase. This accumulation persists throughout the venous phase, which is diagnostic. Also, feeding vessels show crowding around the lesion. Tagged red blood cell scans. Hemangioma may appear as a hotspot on delayed technetium labeled red blood cell scan. These scans are of limited value for deeper parenchymal lesions. They may appear as a filling defect in the liver, which is a finding similar to that in cases of other hepatic lesions. Percutaneous biopsies are contraindicated when hepatic hemangiomas are suspected, as it is associated with a high risk of serious complications and low chance of obtaining tissue for diagnosis. Atypical hemangioma. Only 55% of cases show the previously mentioned typical enhancement pattern. Atypical hemangioma mostly is echo-poor, especially in fatty liver. The atypical features appear in lesions more than 6 or 8 centimeter. The reasons for these features are hemorrhage, necrosis, cystic change, complete thrombosis, sclerosis, and hyalinization. The imaging features may be centrifugal enhancement, inside out, only peripheral enhancement, only central enhancement, diffuse enhancement, arterioportal shunting, washout. Also, atypical hemangioma may be hard on elastography. Complications are mostly observed in large hemangiomas and can be divided into alterations of the internal architecture, such as with inflammation, intratumoral hemorrhage, spontaneous rupture, coagulation abnormalities, which can lead to systemic disorders such as hemorrhage and subsequent hemoperitonea. Compression of adjacent structures. Kasabach-Merritt syndrome is an exceptional complication of hepatic hemangioma in adults. This coagulopathy consists of intravascular coagulation, clotting, and fibrinolysis within the hemangioma, and it may progress to secondary increased systemic fibrinolysis and thrombocytopenia. The syndrome is reversible after removal of the hemangioma. Treatment of hepatic hemangiomas. It is important to note that the majority of incidentally diagnosed hemangiomas require no intervention at all, as 10 to 20% regress. Observation can be appropriate approach in patients with asymptomatic disease, even for females who are pregnant or are taking oral contraceptive pills. The non-operative therapies are of limited success and should be considered in patients with symptomatic disease who are poor candidates for surgical resection due to comorbidities, or if the patient refuses resection. Additionally, non-operative approach can be adopted as the initial therapy in patients with spontaneous or traumatic rupture to gain hemostasis. Such therapies include transarterial embolization, percutaneous radiofrequency ablation, percutaneous ethanol ablation, and radiation therapy. Surgical management is indicated for cases with atypical appearance suspicious for malignancy or acute hemorrhage or thrombosis or rupture. The surgical resection is curative and long-term outcomes of all patients remain excellent, and this includes inoculation or non-anatomic or anatomic resection. Liver transplantation is mandated in patients with unresectable giant hemangioma or extensive multiple hemangiomas or those with inadequate functional reserve after resection. Focal nodular hyperplasia. Focal nodular hyperplasia. It is the second most common benign neoplasm of the liver after hemangioma, typically occurred in young females, with females are affected as 3 times as males. The high prevalence occurring in females taking oral contraceptive pills. It is usually discovered incidentally, but right upper quadrant pain may be the presenting feature. The mass is usually less than 5 centimeter in diameter, maybe multiple. The mass is often located near the surface of the liver. In other words, it is exophytic in nature. Although the focal nodular hyperplasia is highly vascular, it is unlikely to result in hemorrhage. A focal nodular hyperplasia is a benign hyperplastic response of the liver to a congenital arteriovenous malformation. This hypothesis suggesting that the increased arterial flow hyperperfuses the local liver parenchyma and leads to secondary hepatocellular hyperplasia. It is composed of hepatocytes, Kupffer cells, blood vessels, and primitive bile ductules not connected with the biliary tree. A central fibrous scar containing a small arteriovenous malformation may be present. Focal nodular hyperplasia is not a true neoplasm. It is paler than the surrounding liver tissue. It is rarely encapsulated and may be pedunculated, as in this photograph. The central stellate scar is characteristic for this lesion, and this actually composed of ductules and venules rather than a true fibrous scar. Ultrasonography. Grayscale imaging shows a mass in the right lobe of the liver. The mass is isoechoic to the surrounding liver parenchyma and is causing contour deformity. The color Doppler shows a central spider pattern with multiple vessels radiating peripherally from the center of the lesion. The contrast-enhanced ultrasonic examination shows a small central enhancement of the lesion with a spoke wheel appearance. In portal venous phase and late phase shows persistent homogeneous enhancement with iso-enhancing appearance. On pre-contrast CT scans, focal nodular hyperplasia is demonstrated as a focal hypodense or isodense mass. On contrast CT examination, the lesion enhances rapidly at the arterial face, while the central scar doesn't enhance. On the portal face, the lesion enhancement decreases, maybe or slightly hyperdense relative to the normal liver. The central scar enhances over time. In the delayed phase, the lesion becomes isodense and the central scar shows delayed enhancement due to slow washout. This is an example of a contrast-enhanced spiral CT scan. The arterial face demonstrating a solid hypervascular hepatic mass indicated by the arrow with hypodense central scar. The subsequent delayed post-contrast image showing that the mass indicated by the arrow is isoindense to the adjacent liver, while the central scar shows enhancement indicated by the arrow head. MRI examination. The pre-contrast T2 and T1 weighted magnetic resonance imaging show two hyperplastic focal nodules which are iso-intense in T2 and hypo-intense in T1. Gadolinium enhanced T1 weighted MRI image obtained at the arterial and delayed phases shows strong homogeneous enhancement of the lesions with progressive fading in the last photo. Large lesions located in the left lobe of the liver may cause a pressure effect on the adjacent structures with resulting symptoms. The lesion may be felt when it is pedunculated and can be responsible for acute episodes of pain because torsion on the pedicle. Complications of focal nodal hyperplasia such as rupture or bleeding are exceptional and are usually related to the atypical forms of focal nodal hyperplasia with specific imaging and biological features, the so-called telangiectatic focal nodal hyperplasia, which should be classified as an adenoma. Malignant change has never been reported in focal nodular hyperplasia, but may occur in association with hepatocellular carcinoma and other tumors. Most lesions don't require treatment or even regular follow-up. The indications for surgery are rare and include clear symptomatic patients, increase in size, radiological signs of intralesional hemorrhage. The safer resection procedure is liver resection with a surgical margin rather than inoculation because large veins often surround the focal nodal hyperplasia and renders inoculation difficult. In some symptomatic patients with large focal nodal hyperplasia located in the right liver or in the caudate lobe, the resection is difficult or risky. So transarterial embolization is an attractive treatment with reduction of the size in conjunction with the relief of symptoms. Here in these two slices of triphasic CT with contrast before and after arterial embolization, the left slice demonstrates homogeneous centrohepatic focal nodular hyperplasia, shows an immediate and intense enhancement during the arterial phase. The right slice demonstrates post-embolization decrease in size and complete devascularization of the lesion, which appears as a homogeneous unenhanced area. Also, percutaneous radiofrequency ablation has been described. Hepatocellular adenoma or liver cell adenoma. Hepatocellular adenoma is a benign tumor of epithelial origin, occurring primarily in females of childbearing age. The females to males ratio is 9 to 1. It is almost occurs in females taking oral contraceptive pills and occasionally in males receiving anabolic steroids. It is also associated with metabolic diseases such as glycogen storage disease type 1 and 3, and the tumor usually develops before the age of 20 years, also in cases of familial adenopolyposis coli and cases of iron overload as in thalassemia major. Adenomas are multiple in 1/3 of the patients, and if the number exceeds 10, the condition is called liver adenomatosis. The liver adenoma also are reported in males and females in the absence of oral contraceptive pills and anabolic steroid use or glycogen storage disease. The pathogenesis is still unclear. However, strong association with oral contraceptive pills and pregnancy suggests a possible trophic effect of estrogen on this tumor. Furthermore, regression of adenomas after discontinuation of oral contraceptive pills is well documented. There are 4 subtypes of hepatocellular adenoma. The most important of them is the beta-catenin mutations subtype and inflammatory hepatocellular adenoma. The tumor is commonly located in the right lobe of the liver, usually solitary, sometimes pedunculated. Typically, the size ranges from 5 to 10 centimeter in diameter, but may reach up to 30 centimeter. It is well circumscribed and surrounded by a pseudocapsule. A large subcapsular vessel are commonly found. The adenoma is supplied by the hepatic artery. On the cut section, it is heterogeneous because of their mixed components of fat, hemorrhage, and areas of necrosis. Usually, no fibrous septa or central scar is present. Adjacent liver, as we see, is non-cirrhotic. Hepatic adenoma doesn't have normal hepatic architecture and is composed of benign hepatocytes arranged in sheets and cords and form normal or thickened trabeculae interspersed with prominent arteries with thin-walled blood vessels and sinusoids. Septa, portal tracts, and bile ductules are absent. Coffer cells are absent. There are areas of degenerative changes as hematoma, infarction, necrosis, dilated sinusoids, blood-filled spaces, myxoid stroma, rarely contains abundant fat. The cells are typically larger than normal hepatocytes and contain glycogen and lipids. No cellular atypia. The nuclei are small and regular with rare mitosis. The clinical manifestations and complications. Tumor commonly may be detected as an incidental finding on abdominal imaging or at surgery. However, hepatocellular adenoma may present in different ways. Typically, the patient is a woman between 20 to 50 years who has a history of more than 5 years of oral contraceptive pills use. In most cases, the patient presented with abdominal symptoms, usually pain or discomfort in the epigastrium or right upper quadrant. Hemorrhage results in acute pain accompanied by anorexia, nausea, vomiting, and fever. Presentation can be with severe pain and associated with hypotension in the setting of an acute hemorrhage or rupture. The general risk of bleeding and rupture appears to be more likely in those patients taking oral contraceptive pills and the inflammatory group. The risk of bleeding in the inflammatory adenomas is reported to occur in up to 30% of cases. Bleeding is generally limited to larger adenomas, usually more than 5 centimeters in diameter. The mortality may be as high as 6%, but recently it is rare. Malignant transformation of hepatocellular adenoma is uncommon but well documented. In most series, 5 to 8% of cases are associated with hepatocellular carcinoma. The size is a good predictor of malignancy, and hepatocellular carcinoma occurring in adenomas more than 5 centimeters in diameter. Transformation from adenoma to carcinoma may occur despite the discontinuation of oral contraceptive pills. Beta-catenin mutations are associated with most hepatocellular carcinoma. The risk of malignant transformations appears to be significantly higher in men, regardless of beta-catenin mutations. It may reach up to 50%. The signs of transformation are an enlarging lesion, local or systemic symptoms, progressive abnormalities in liver chemistries, and rising the blood levels of alpha-fetoprotein. By traditional ultrasound examination, the findings are non-specific as adenomas may be hypo, iso, or hyperechoic, but are typically heterogeneous. On contrast-enhanced ultrasonography, adenomas usually show moderate and heterogeneous hyperenhancement in the arterial face with centripetal or diffuse filling, described as chaotic vessels. In the portal and late phases, these lesions tend to become progressively isoechoic. Sometimes they exhibit a mild washout that may cause misinterpretation as malignant tumors. By contrast, enhanced spiral CT examination, the findings are similar to that of the focal nodular hyperplasia. So in the arterial phase, we can find early enhancement of the lesion with slightly enhanced central scar. In the portal phase, the lesion exhibit wash out and the surrounding liver tissue start to enhance. In the late phase, there is a complete nearly complete washout, and the lesion appear iso attenuated with the surrounding liver tissue. Here in the unenhanced CT, we can see a low attenuation mass in the right lobe. In the arterial face, we can see the early intense enhancement of the lesion. In the portal venous face, the lesion shows washout. By MRI, the lesion is iso-intense in both fat-suppressed T2 weighted image and in T1 weighted image. The most accurate diagnosis is by MRI with gadolinium enhancement. Here in the arterial face, we can see the strong lesion enhancement, and in delayed phase, we can see the washout. In the treatment of hepatic adenoma, the risk-benefit ratio should be assessed for every case, and the final decision should be made on an individual basis. So the treatment is tailored to the gender and size. It can be either by percutaneous techniques and surgery. First, the females shouldn't get pregnant, and to be followed up, it must be monitored by ultrasound and alpha-fetoprotein. The indications for surgery are lesions more than 5 cm in diameter because of the risk of rupture and hemorrhage and the risk of malignant transformation. Significantly increased alpha-fetoprotein regardless of the size. The surgical approaches include inoculation, resection, and liver transplantation. Inoculation is associated with less blood loss and preservation of normal liver. Resection can be done by segmental or partial lobectomy. Almost all solitary lesions can be completely resected. Laparoscopic resection can be done for small tumors within the anterolateral liver segments and for pedunculated tumors, which constitute about 10% of cases. Liver transplantation is reserved for cases with multiple adenomas or glycogen storage disease because it also corrects the metabolic defects. Arterial embolization can be used to control bleeding, converting a high-risk emergency resection surgery into a low-risk elective case. Embolization can also reduce the tumor size preoperatively or relieve symptoms in patients with inoperable tumors. Patients with ruptured hepatic adenoma should be treated electively after stabilization of the patient and selective hepatic artery embolization. The patient can be observed for several months until resorption of the hematoma surrounding the tumor. Radiofrequency ablation can also be used for small tumors. Part 2 will cover the following topics: lipomatous tumors, infantile hemangioendothelioma, mesenchymal hamartoma, inflammatory pseudotumors, biliary cyst adenoma, bile duct adenoma, and papillary adenoma. Thank you.